By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast.
Welcome, everybody, to another edition of Let's Get Real with NCAN. I am your host, Mike Wayman, and today we're going to have Dr. Soulen. He's going to talk to us about liver-directed therapy. But first, before we jump into that, I do want to remind you guys that there is the 2022 Net Patients National Conference. It's the first national in over 3 years. This is 3 years in the making. We were supposed to do it 2020, and of course, COVID stopped those plans. But it's taking place. It's finally taking place. Zebras take over Atlanta. Hashtag Zebras take ATL. It's at the Marriott Marquis. There's going to be 20 plus net experts there to present and to answer your questions. So if you need more information on that, please go to our website, netcancerawareness.org. And also all the social medias. They're back up, they're running, ready to go, and we're interacting with everybody. So at NetCancerAware, you can catch us on LinkedIn, you can catch us on Facebook, Twitter, Instagram, everything. So without further ado, I would like to welcome in our guest, Dr. Soulen.
Hello, everybody. Good morning.
Thank you so much for joining us today. Before we get into your presentation, please just let everybody know a little bit about yourself, where you're practicing, all that kind of stuff, your specialty, and
sure. All right, so I'm an interventional oncologist, which is an interventional radiologist who specializes in treating cancer, just like a surgical oncologist is a surgeon who specializes in treating cancer. I have been at the Abramson Cancer Center at the University of Pennsylvania for my entire career, so now for over 30 years. And the major focus of my own practice is cancer-related therapies, which include ablation and embolization and palliative procedures, mostly in the liver, but also really any other solid organ accessible to us. So we treat, tumors in the lung, in the kidneys, in the musculoskeletal system, occasional other places. And then, of course, as I mentioned, we also do palliative procedures for management of pain or ascites or other late complications that sometimes happen in cancer patients. My practice evolved over the years to become primarily focused on neuroendocrine patients. I can honestly say that wasn't a conscious decision. It really was an evolution because, as you know, neuroendocrine patients stick around for a very, very long time. And most of the other patients with malignancies in the liver that we treat have much more aggressive tumors, such as primary liver cancers and colon cancers. And the sad truth is they don't tend to survive very long. So if you stay in one place long enough, gradually your clinical practice just fills up with neuroendocrine patients because they just keep coming back and coming back and coming back. And since I've been there the longest, most of my practice became dominated by neuroendocrine patients. So it's very logical to make that a clinical focus. After founding the initial liver tumor board, we then went on to found a dedicated neuroendocrine tumor board at Penn, which I helped start. And I'm the lead interventional oncologist for the neuroendocrine tumor board at Penn. In addition, most of my research focuses around clinical trials nowadays. And so a number of those trials, of course, have to do with neuroendocrine tumor patients. So I'm the principal investigator for the RETNet trial, which probably many of you have heard of. The RETNet trial is the first ever randomized embolization trial comparing bland embolization and chemoembolization in neuroendocrine tumor patients. And it's a global multi-center study, so Canada, the US, South America, and Europe. And I'm very excited to say we finished accrual to the study in April of this year. So that was a huge milestone. And now we just have to wait for the enrolled patients to be followed, because our endpoint is progression-free survival in the liver, and it'll take us a couple of years for that to read out. But we're excited to have finished accrual to the study. The other multi-center trial we're doing now is one that we are integrating CAP-10 therapy with yttrium-90 radioembolization, looking for the synergy between the radiosensitizing chemotherapy drugs and the Y90 to see if we can't get better response rates and more durable response rates for patients who present a little bit more aggressively with grade 2 tumors. That trial is based on a feasibility study we did some years ago showing that it was safe to combine the chemotherapy and do the radioembolization simultaneously. And in our early experience, I have to say both the response rate and the duration response are astonishingly good. I mean, even I don't believe it's that good. But that led to the funding and starting of a multi-center prospective phase 2 trial. We're going to do about 50 patients across 3 centers to get a better handle on the efficacy of this therapy. So those are the 2 of the trials that I'm doing among several oncology studies that are focused on neuroendocrine tumors.
That's great. That's great. So a couple episodes ago, we did speak to Dr. Mary Maluccio, and she presented a little bit about clinical trials and why it's so important for patients to get involved with them and not necessarily get discouraged if you're not chosen, and also don't be afraid to do it, because without your help, without you pitching in, these things don't move forward, and that's what we all need. We need to find things that are going to treat this cancer and stuff. So it's very, very cool that you're involved with so many different trials. That's got to be daunting for sure.
And I'm very proud of some of my NET patients who actually first. They actually did both trials. So wow. They were in the NET study years ago, and when they eventually progressed after sort of their first-line liver-directed therapy with bladder chemoembolization, they then enrolled in the CAP-10Y90 study and are now getting the doubled-up chemoradiation therapy. So, that's a good example for you, to your point about neuroendocrine patients really stepping up to the plate and helping to contribute to helping us understand better ways of treating everybody.
Yeah, absolutely. And what I do like is how you didn't find NETs found you.
Yeah.
You kind of were pulled into this, and I'm kind of besides my mother being a patient, but just going to all these conferences for the past 20 years, I became a part of the community as well. It's something that picks you, and it's great that everybody is long term, and even when people's families, their loved ones pass away from the disease, they're still always involved, and that's huge. So very cool that you've been involved for 30 years. It's huge. It's huge. So thank you for everything you've done.
Sure.
Why is it important for patients to be involved with their treatment plan? Why do you think?
Well, I think, this has to do with sort of patient-centered care. And, I'm a very firm believer in autonomy. That's one of the fundamental principles of providing ethical medical care is preservation of patient autonomy. The reality is most patients that I see have metastatic cancer, whether it's neuroendocrine tumor or some other kind of cancer. And the reality is that we don't really think about curing people with metastatic disease. We think about controlling it and preserving quality of life and in ways that are meaningful to the patient. But the reality is many patients will succumb to the disease eventually. So, there are a lot of choices in therapy. Every choice of therapy has its benefits and its risks. So you're basically weighing the odds. And it's my job to present the odds. I say, okay, we could do X, Y, or Z treatment, and these are the chances of this benefiting you, and these are the chance of something bad happening. And the patient gets to decide. The patient's the customer. So patients have to be very informed and involved in their own care, because you have to make a lot of decisions. And the good thing I suppose, with neuroendocrine tumors versus some of the other things we treat is that we got a lot of bullets in our gun. You know, probably have, I think of it as a 6-shooter. We got 6 lines of therapy that can be used over time. And we know how well they work and we know their risks. But for the individual patient, the question is, when do you pull the trigger? You know, what treatment do you do when, in what sequence, and how long do you wait in between? And that is a role where the patient's decision-making process is super important, you know, in terms of thinking. And, you know, different patients have very different attitudes toward the same treatments for the same tumor. So, you know, you really, I mean, the days where you just do what your doctor told you to do are long gone. You know, there are too many choices to make. And, you know, I tell my patients all the time, you're the customer, you get to decide. And not everyone wants to hear that, but that's the reality of the way it is. And, you know, we will work together and guide you along that. But that's a conversation that we're going to have many times over the course of disease. You know, it's a common scenario, for example, that let's say I did a cycle of treatments for someone's liver metastases, and the typical pattern is they respond, and the next scan is better, the next scan is better, and the next scan is better, and then they plateau, and then they're plateaued for a while, but inevitably they recur eventually. But I treated you for this much disease, and now you have this much disease. So just because you had your first sign of recurrence doesn't mean we have to do anything yet. We may just keep scanning you and scanning you and scanning you until eventually we agree with each other it's time to play whack-a-mole again. And so, that's a shared decision-making process. And the patient's feelings are extremely important in that. So, there's no substitute for being engaged in your care, being informed about your options, understanding all the choices you have to make, because at the end of the day, the patient makes the choice.
Absolutely. Absolutely. Now, in regards to getting that proper care, what is the most important decision that a NET patient can make?
Well, there's really two-step process in my mind. One is you have to find an expert neuroendocrine team. And, there are many centers scattered around the country and around the world where there are centers of expertise in neuroendocrine cancer, but, the patients are far more widely spread than that. So, you're going to get, there's a lot of people who get diagnosed who are maybe, 100 miles or more from the nearest, a center that has an expert NET team. And you need to access those expert teams. The people in the community just, as well educated as they might be, they don't have the advantage of a multidisciplinary team. And, every one of us who does a particular therapy, whether you're a surgeon, an interventional oncologist, a radiation oncologist, or a medical oncologist, when you're a hammer, everything's a nail. We all know what we do it well, I hope. But the reality is that for any one patient, if you talk to any one expert, they'll tell you what they do. But what you need is to be reviewed by a team. And, we have a weekly meeting of our neuroendocrine tumor board, and anyone who's up for who's at a branch point in the decision-making for their treatment, we discuss as a group. And, what I think I can offer may not be the best choice at that point in time. So I think, first of all, it's important to get access to an expert neuroendocrine team. We're going to get multidisciplinary advice. And that doesn't mean you have to be treated there, right? So a place like Penn, we do lots of secondary consults, right? Lots of people get referred in just for a second opinion. Like, I come from wherever that's 3 hours away. This is what my doctor has recommended. What do you think? And most of the time we agree, right? But, you can still get treated someplace conveniently close to home that's not too disruptive. But you need to access multidisciplinary care at some point in time. Having done that, though, then you need a quarterback, right? So, what I keep telling my patients is you don't need 3 doctor's appointments to tell you what one scan showed, right? So you may have started with a team, and often with new patients, they'll actually cycle through consults with a few of us. We'll review them in tumor board, say, okay, they should talk to surgery, interventional radiology, and nuclear medicine. And you do all that, and then we come up with a treatment plan. But once you have that treatment plan, you need a quarterback. And, it has to be someone the patient trusts, who communicates well, but they really want to settle with the one person who's most actively involved with their treatment. So, if I treat patients, then I follow them. And I follow them until the time comes when I'm going to hand them off to one of my colleagues who's going to start a completely different line of therapy, in which case they can follow them. But, I think both for efficiency and communication and avoiding disrupting your life, you need a quarterback, the one doctor that you're going to go see on a regular basis. And that will simplify your life because you don't have all these doctor's appointments all the time. And you just have to count on that person to communicate with all the other doctors to keep everybody in the loop.
Absolutely. Yeah, that's something that it comes up constantly. So any new patients or people who are new to this subject of neuroendocrine cancer, multidisciplinary teams are number one. It's huge. It's to get in front of a bunch of experts is not something that you'll have to do constantly, weekly, monthly, whatever it may be, but definitely go to a team at least once in your life. It's important because once you do it once in your life, you'll know why you're going to continue doing it.
Sure. And Mike, especially with telehealth now, it's made it easy to get access. Like you don't have to travel necessarily if you're remote.
Oh, sure.
You can get remote consultations now without having to travel. Such a great thing for patients in terms of breaking down the barriers. And then, of course, there's a subset of patients who don't just go to one neuroendocrine specialty center. They'll actually shop around and maybe go to 2 or 3. So I have patients who see us at Penn, but they also consult with Memorial Sloan Kettering Cancer Center up in New York, or maybe they go out to New Orleans, and get consultation down there, or maybe they go out to Colorado and see Eric Liu. I mean, so you actually have access, if you want, to multiple multidisciplinary teams, and I can assure you they will all give you different advice.
Sure. Yeah, absolutely. Now, as far as like telehealth and stuff like that, I've done a few telehealth appointments myself. Do you think it's a viable, maybe not replacement, but a viable means to treat?
It is such a great thing. It is so good for the patients, and frankly, it's more efficient for me. Honestly, I mean, during COVID, we were all telehealth, and now that the emergency licensures have all ended, we're kind of back to a mix. Because remember, a doctor cannot provide you a telehealth consultation unless he or she is licensed in your state. That's legal law. So that's now put up a barrier where now all of a sudden we have to get state licenses in all these adjacent states because being near the edge of Pennsylvania, we get a lot of Delaware patients, a lot of New Jersey patients, some New York patients, and I can't do telehealth with them anymore legally until I get licensed in those states. But the reality is, for follow-up especially, if I treat a patient, what's the follow-up? It's labs and a scan, and I need to see how you're doing. I do not need to lay my hands on you physically, but I need to have your images from your scan to review. I need to see your laboratory results. I need to talk to you, preferably by video, because a picture is worth 1,000 words, and just seeing someone tells you so much about how they're doing. And that's really all I need. And you can get scanned near home. People really don't like having to come into West Philadelphia to Penn to get their scans. The traffic's terrible. The parking's expensive. The medical campus is enormous. You have to walk for like a mile to get between appointments. Who wants to do that? I'd say the biggest challenge is, from my standpoint, is the imaging part. You need to get image in a place where I can see the pictures. You can't manage patients off outside dictated radiology reports. You have to actually see the pictures for yourself. So, Penn has a fairly widespread system. So patients who are within an hour or so can often get scanned somewhere that's part of the network, in which case their images go right into our packs. But the patients who don't, we need to get those images transferred or have a disk sent and uploaded before the appointment so I can actually review the images. So that's a little bit of a logistical challenge with telehealth, but still, easily overcome, and makes life so much better for the patient. New patients, I kind of prefer they still come in, because if it's someone brand new, first of all, it's gonna be a much longer conversation, and there's something you get out of a face-to-face encounter that's a little richer, even though we're both wearing masks. So I like to see new patients face-to-face if I can. Plus, then you can get consent for procedures, which you can't do remotely anymore, and so some advantage of that. But the follow-ups for sure, so much better for the patient, and honestly, because all the information is there ahead of time, I can, essentially prep the night before for all my telehealth visits and already have reviewed your labs and your scan and your recent doctor's visits. And it makes my job actually way more efficient when it comes to actually seeing the patients. So things, we come to conclusions faster. We can take the next steps quickly. So telehealth's a great thing. I hope it stays.
That's great. That's great, because I know a lot of people are hesitant. They're a little hesitant to embrace the online stuff and online information and telehealth and whatnot. But it really is a great tool. So
I mean, you definitely have a subset of the population who's not going to use it. You have people who are just not hooked up technologically. I mean, especially in big urban environments. I mean, 25% of Philadelphia does not have internet access. So there's always going to be some people where it's going to be a phone call, and I find the phone calls a little dissatisfying. I mean, they're okay, but without the video, you've lost something.
Yes, for sure. Awesome. So you're going to talk to us about liver-directed therapies. Yep. So without further ado, I'm going to give you the floor and let everybody know about it.
Okay, we'll do that. So I thought we'd just approach this the way I would approach any new patient I was seeing in my office. So I'm not going to show you slides. We're just going to have a conversation. So the first question is why would you be seeing someone like me? Why would you be consulting with an interventional oncologist about liver-directed therapy? And the reality is that 9 out of 10 patients with neuroendocrine tumors get metastases to their liver. Half of those have it when they're diagnosed, and the other half come in subsequent years. But it's an incredibly common scenario. And to us, it is the major organ at risk, the liver. We somewhat tongue-in-cheek say you don't die from bone mets and lymph nodes, which isn't 100% true. But the reality is, if you dial back to 1980, the life expectancy from patients with metastatic neuroendocrine tumor was 3 years. And what did those patients die from? They died from liver failure, or they died from uncontrolled hormone secretion from primarily their liver mets. And then along came two things, octreotide or sandostatin and liver embolization to control liver mets. And the life expectancy jumped from 3 years to 10 years. So, keeping the liver functioning is one of the most important things in patients who have metastatic disease to the liver, because that's, in most cases, what kills you in the end if you don't have that under control. So very, very important to keep the liver mets under control. And, nothing has a higher response rate in the liver than liver-directed therapy, as opposed to any systemic therapy. So then the question becomes, among the patients with liver metastases, when do you need this level of intervention? So, the first line therapy in almost everyone is going to be octreotide or lanreotide. And as we know, in many patients, even though they rarely see shrinkage of their tumors, can happen, that's pretty rare, you often get stabilization, and you can get that stabilization for a very long time, even in patients who present with sort of medium bulky liver mets. I mean, I have some patients who, they walk in the door, you look at their scan, and there's multiple metastases as big as 8 centimeters in their liver. And, I immediately start salivating like Pavlov's dog, saying, oh, God, I got to embolize you tomorrow. And they're like, well, wait a minute, what about just going on shots first? And, you put them on the shots and their symptoms go away and their tumor stops growing. And I have patients who've been on sandostatin for, 5 years with liver mets and never needed liver-directed therapy because they never progressed once they were on an SSA. So that's going to be first-line therapy in almost everybody. And then, so once you're on an SSA, what would be the indication for considering doing liver-directed therapy? So if we look at guidelines, both in the US and internationally, it's your tumors progress despite being on octreotide or lanreotide, or you have uncontrolled hormone-related symptoms, be it carcinoid syndrome or some other specific hormone-related symptom that's not controlled with the octreotide. Or the third category is people who walk in the door with a very, very heavy liver tumor burden, where we just don't want to risk waiting, because if they progress any further, they might run out of liver. And, and because neuroendocrine tumors progress so insidiously, and the liver has such tremendous reserve. Remember, you only need a quarter of your liver to get by. So the tumor can be in there and it can take over 70% of your liver, and you will never know unless you happen to get a scan. So if someone walks in the door and half their liver is already overtaken by tumor, then we're not going to mess around, because what you don't want is for that tumor to progress and the person to run out of that last 25% of liver, because once the liver fails, there's no coming back. Up to that point, you're doing okay. So we sort of view quality of life in patients with liver metastases like a plateau with a cliff. So you're going to cook along feeling just fine, and your liver's going to work just fine until you run out of liver, and then boom, you fall off the cliff, and usually death ensues within weeks at that point, and it's too late to get you back. So we want to drag people back from the edge of the cliff. So the three scenarios we would consider are, you're growing on an SSA, you're symptomatic on an SSA, or you just walk in the door with a pretty worrisome liver tumor burden, and we just need to treat you right away and debulk you. So once you hit that point, then what do you do? So remember, debulking the liver can be done in many ways. So one is surgery. And so one of the things I always look at is this patient a candidate for surgical debulking? Because some people have good anatomy for that. And that's why we have surgeons on our tumor board. So I look at, is there a surgical option? And if I think there might be, then I consult one of our surgeons. And to be efficient for the patients, what I'll tell them is, look, you don't have to go see the surgeon yourself. I'll have the surgeon review your chart, review your scans, and let me know if you're a surgical candidate or not. And if you are, then you can go see the surgeon and talk about it. Doesn't mean you have to have surgery, but at least you'll be educated. And if the surgeon flat out says no, then you don't have to go through that step, and we can just move ahead. So if you're not a surgical candidate, then we're going to do, well, it's going to be some form of embolization. And embolization means catheterizing the artery of the liver and then injecting something through that artery that's going to treat the tumor. And this is a very historic therapy. So embolotherapy for neuroendocrine tumors dates back to the 1970s in France. So it's been around for a very, very long time. And in the beginning, it was done with techniques that we now call bland embolization, meaning doctors used some form of particulate agent, and there were many, but some sort of solid agent to inject through a catheter and plug up the artery that fed the tumor and kill the tumor. But there was no chemo or other thing involved. And the reason you can get away with that has to do with the plumbing of the liver. So the liver is an unusual organ in that it gets its blood supply from two places. So the normal liver gets most of its blood from the portal vein. The portal vein is a huge vein the size of a hot dog that drains the blood from your entire GI tract to your liver. And the liver that does its thing to process the food you digest, etc. And then the blood returns from veins that leave the liver back to your bloodstream. That's how the metastases get there, because the tumors largely arise in the GI tract or pancreas, and when those cells float away, they float out through the veins and out the portal vein, and the liver filters them out. So that's why liver mets are so common, because it's the first filter for the blood coming from the tumor. So the normal liver is getting 3/4 of its blood from this huge vein and 1/4 from a little artery called the hepatic artery. But the tumors, once they establish themselves and grow in the liver, they get all their blood from the artery. So because of that difference in plumbing, we can catheterize the artery of the liver, just like people do heart catheterizations. We do liver catheterizations. We can find the branches to the tumor, and then we can plug them up. That's called embolization. And when you do that, you cut off almost all the blood to the tumor, so they largely die. And you only take 1/4 of the blood away from the surrounding liver. So the liver is temporarily unhappy. If you were to measure liver function blood tests, you see the enzymes spike way up for a few days, and then they'll come back down to where they were in about 10 or 14 days. So the liver will recover, and there's no permanent effect on the liver, but the tumor hopefully will die. So that's been done for now 50 years. And we know the response rate is quite high, and we know that it's also, on average, quite durable. Then in the 1980s, people started saying, well, gee, if we're going to choke off the blood flow to the tumor, why don't we take a spoonful of powdered chemotherapy and mix it with our embolic material and inject it all together? So now we'll cut off the blood flow to the tumor, and we'll deposit super concentrated chemotherapy, not very much, but it'll get trapped in the tumor and get stuck in there for weeks, and very little will leak out to the bloodstream, so there won't be much effect on the rest of the body, and we'll be killing the tumor two ways, chemo and embolization. So that sort of became standard of care in the 1980s and was really developed for the treatment of primary liver cancer. And the studies, clinical trials that established the value of chemoembolization were done in primary liver cancer. But it became sort of standard practice worldwide, and that's what most people do, even for neuroendocrine tumors or other types of metastases. So the question that never got addressed is it actually better than bland embolization for NETs or any other kind of cancer for that matter? And those studies were never done until the RETNet trial that I mentioned earlier, which we just finished enrolling. So after half a century of doing these therapies, we finally got around to doing the clinical trial to try to determine whether there's a difference between bland embolization or chemoembolization. And we're looking at effectiveness. How good is it at treating the tumor and keeping it from progressing? We're looking at toxicities and side effects. So there's one more risky than the other. And we're also looking at the patient-related experience. So there's neuroendocrine tumor quality of life surveys that all the patients are completing, so we can see if they have a different experience between the two therapies. And any of those three domains could end up being different or not. So we'll know that in a year or two. So bland and chemoembolization are considered equivalent for now in the absence of any data to the contrary. And they're in, as I said, all the guidelines as first-line therapy for liver-dominant metastases that have a reason to be treated, such as progression or symptoms. They work quite well, as I said. The response rate in terms of symptom control is 85%. The response rate in terms of shrinkage of the tumor, and remember, as oncologists, there's a very strict definition of response, which means the tumor has to shrink by 30% or more in diameter. That's about 60%, 65%. And then the duration of response depends a little bit upon the grade of the underlying tumor. So low-grade tumors usually get a couple years, grade 2 tumors closer to a year, and then grade 3 tumors don't do well no matter what you do, and you get maybe half a year on average. But that's the average. So some people do way better than that, some people not as well. And then in terms of the patient experience, if you do bland or chemoembolization, almost everybody gets what's called post-embolization syndrome. And that's a constellation of symptoms that most people get if we embolize any solid organ in the body. So that's a mixture of pain, nausea, fever, loss of energy, loss of appetite, sometimes a flu-like syndrome that can last from days to weeks. And it's highly variable in severity. Some people bounce right back, go to work the next day. Some people are still wiped out a month later. Most people are somewhere in between. But those are all expected side effects that we see. And, it's one of the reasons why we don't treat the whole liver at once, because we don't want to make people too sick. So we generally don't do more than a lobe of the liver at the time. So if you have metastatic disease throughout the liver, you're going to get staged therapies. You'll get 2 or 3 of these procedures. And it's typically done about a month apart. Again, allowing time for recovering in between. Nothing magic about the 1 month. And then you're done. And so after your 2 or 3 procedures, then we get a follow-up scan and see how we did. And we want to see is a bunch of dead tumor that's going to shrink away over serial scans. And then we just go back into surveillance mode. People do stay on their shots during this time and afterward. And then in terms of risk of the procedures, could something bad happen? Of course, the answer is yes. Everything has its complication rate. It's about 5% for bland or chemoembolization. And those are mostly either damage to normal liver or infection, and then a host of other rare things. So that, I would say, is what most people are going to be offered as far as first-line therapy. The newer kid on the block, which many of you may have heard of, is radioembolization, or Y90, or TARE, or CERT, a bunch of different names for it. But basically, instead of plugging up the artery to the tumors by injecting an embolic that will occlude them and cut off the blood flow, instead you instill millions of little radioactive seeds that will sail out through the catheter, get embedded in the tumor, but not occlude the artery because they're tiny, and then they will radiate the tumor from the inside out. So that's radiation therapy, just delivered through a catheter. So just as many of you may have heard of men getting seeds in their prostate to treat prostate cancer, this is injecting millions of seeds into the liver through a catheter to embed themselves in the tumor and radiate that tumor from the inside. So radioembolization has been around since the early 2000s. We don't know if it's necessarily works any better than the more traditional bland or chemoembolization, and there's no trials that have really examined that question. But if you look at the series that have been published on it, it seems that overall the efficacy is similar. That is, the response rate and the shrinkage of the tumors and the duration of benefit don't seem to be obviously dissimilar from bland or chemoembolization. That being said, there are some patients for whom it's probably better because it's safer. So there's a group of patients who've had prior intervention on their bile duct. So maybe they had a pancreatic neuroendocrine tumor and they had a Whipple surgery where the bile duct was cut and sewn back to the bowel, or maybe they had a blockage of the bile duct from the tumor and an endoscopist put a stent in or did a sphincterotomy, cut the sphincter. But once any of those things have been done, the bile ducts get colonized with bacteria because normally the bile is sterile. There's a one-way valve at the end of the bile duct where it plugs into the bowel so your bile can flow out to help you digest your food, but the bacteria that live in your gut don't get into your liver. But once that duct's been cut or stented, then you have bugs in your bile ducts in your liver, which normally doesn't bother you unless we embolize you. Because when we embolize you, just like the tumors, the bile ducts also get the blood supply from the artery. So you get microscopic bile duct injury, which in a normal patient wouldn't cause any kind of problems. But if you have bacteria in there, they can get out in the liver and get a liver abscess. So that's a risk that we recognized many years ago. Actually, one of my medical students figured that out a long time ago when we realized that everyone getting abscesses had either a Whipple or a stent. So now those patients get big gun antibiotics for weeks. And even then, you still get abscesses in about 20% of patients with bland or chemoembolization. It turns out, when we do reembolization, since we're not cutting off the blood flow through the arteries, we don't injure the bile ducts, and so the infection risk is much lower. It's probably about 7%. So in patients who've had prior bile duct intervention, I'll typically do radioembolization as my first-line treatment instead of bland or chemoembolization, just because it's safer, much less risk of getting a liver abscess, which is a pretty devastating complication. Also, because you're not cutting off the blood flow with Y90 little seeds, you don't get sick. You don't get the post-embolization syndrome hardly at all because you're not cutting off the blood flow to the liver. So I would say half the patients have zero side effects. Maybe 30% get fatigue from the radiation, maybe 10% get nausea, but less than 5% get a true post-embolization syndrome like you would see with chemoembolization. 95% of people do this therapy as an outpatient. So it's extremely well tolerated. And so it may be a better option for frail patients who may not be able to tolerate a chemoembolization, or for patients who are caretakers for a family member or employed and can't miss work, where they need their quality of life not to be disrupted. So that's another option. So those are subgroups you might think about doing that. The major downside to radioembolization is, unlike with chemoembolization, which has no permanent effect on the normal liver, when you inject the radioactive seeds, although the goal is to get the radiation to the tumors, the radiation radiates out from the seeds, so the liver gets radiated as well. So you always get some radiation effect on the normal liver. Usually that's silent, like you wouldn't know it, your labs don't change, but it's there. You get some degree of radiation fibrosis. And then if you get, but most people, that's pretty much invisible, and you could even get a whole second cycle of radioembolization should you progress again in the future. But if you do that, then almost certainly you'll start seeing obvious changes in the liver from like a radiation-induced cirrhosis. And we know that in patients who live for a very long time after treatment, say between 2 and 10 years later, somewhere between 10 and 20% go on to actually develop a radiation-induced cirrhosis that's clinical, meaning they get a shriveled up liver, they get portal hypertension, they get ascites, they might get varices, and they may even die from liver failure with their tumor completely controlled. So now that we recognize that, and we don't see that much in other cancers that we treat because the patients die of their cancer, but neuroendocrine patients live for a long time, and because of that, we have the opportunity now to have followed patients for 10 years or more, and we now are aware that there's a small group of patients who can develop late liver failure after having been treated with Y90. So that has changed the guidelines a little bit in the sense that we now try to avoid treating the whole liver. We try to leave a good chunk of the liver not radiated so you won't end up with liver failure. We try to do this very, very selectively, just to the tumors themselves. And also people are paying a little bit more attention to the dosimetry and trying to make sure that the dose to the, not just focusing on getting enough dose in there to kill the tumor, but making also sure that the liver dose is below a certain level so you won't induce radiation changes in the liver. So those are all considerations when it comes to reembolization. And then, of course, as I mentioned earlier, we have some exciting trials with that. So, for example, the CAP-10Y90 trial, where we're combining reembolization with the CAP-10 chemotherapy in patients who have higher grade tumors and have extrahepatic disease, a little bit more aggressive presentation. We're sort of doubling up the therapies because it seems like the efficacy of the combined therapy is so good and so durable that it probably outweighs the slightly greater risk of long-term complications from the Y90. So, that's the conversation you're going to have with the interventional oncologists you see once you get to the point of, where embolization is the next logical step in your care. And, you have to decide kind of which way you go. I would say, in my experience, the average normal patient who has no mitigating factors like a Whipple or something, we start with bladder chemoembolization. I do both. Pretty much doctor you see, they may favor one or the other. As I said, we don't know that one's better than the other, so it doesn't really matter. You can get, kind of whatever you want in that realm. And then, most people respond to that. And then we just go back into follow-up mode. And if you have a great response to liver therapy, and then you relapse and, 1 to 3 years later, you can get it again. And, because it's not like the tumors get resistant to it. It's just that you now have new tumor that's got a new blood supply, and you can cut that blood supply off with another embolization. In fact, the very first patient I ever treated with chemoembolization at Penn, when I first came there back in 1991, was a neuroendocrine tumor patient. And I embolized him 16 times over his lifetime, which was 25 years after his diagnosis. And we just kept going back and going back and going back every few years as needed to knock off new tumors. And, he had a very, very favorable course with that line of therapy. So I think that kind of summarizes what I do. And Mike, I'll kick it back to you for questions.
Yeah, no, thank you so much, Dr. Soulen. If you want to learn a little bit more about this was a lot of information in a quick period of time, and you didn't get too granular. But if you want to see people get granular, please make sure you head on over to netcancerawareness.org. Sign up to join us at the national conference November 10th through 12th in Atlanta, Georgia. We also have some live streams that are going to be happening exclusively through chapters. So find a local chapter near you. Start a local chapter if you don't have one. Check out some of the videos we have over on our YouTube channel of past doctor presentations. And we're looking forward to all the new discoveries that we hear in the future with your clinical trials and stuff like that. Hopefully, when we see you in November, we get some more updates on that.
Okay. That's great.
Thank you so much. If you guys like this type of content, please make sure you're liking, you're subscribing, you're hitting the bells, all that kind of stuff. It really does help shows like this. And we are all about awareness. And the only way we're going to get awareness out on the internet is to beat that algorithm. So please make sure you're liking and subscribing. Please check out all of our social medias at NetCancerAware. Go to our website. You'll see all of our events. You'll find a local chapter. And thank you again, Dr. Soulen. And
pleasure.
We'll catch you guys next time on Nets Get Real with NCAN.